And to today's webinar on human factors in partnership with NHS, University of Aberdeen and Q Scotland. We're very delighted to have Paul and Helen particularly with us today, and I think we'll go straight over to you, Paul. Thank you.
Thank you very much indeed, David, and hello everybody. I think I know quite a few of you on the call. So I'm Paul Bowie, I'm Programme Director for Safety and Improvement with NHS Education for Scotland. Helen, do you want to come on and quickly introduce yourself, please, if you don't mind?
Sure, thanks, Paul. I'm Helen Vosper, and I'm interested to see, I know quite a lot of the names as well. It's great to see the same people coming back for this. I'm the Patient Safety Lead at Aberdeen University across all healthcare courses, but I also work with NES as a human factors specialist. I will only be here for part of the session because, in fact, our medical students are getting some of this exact stuff in about an hour's time. Thanks, Paul.
Thanks very much, Helen. We haven't been entirely honest with you because this is badged as an introduction to what human factors is and what it's not and what the benefits and advantages are. But we're also dovetailing this with the launch very soon of a brilliant basics teaching pack on human factors for anybody who has any type of educational role and would like to take this on and integrate it within any programmes of education that you're involved with, or do it within your own organisation, your own team. So it's going to be quite unusual in the way that they were in this session, because we're going to introduce you to quite a lot of concepts very rapidly and get some feedback from you. We're going to introduce you to a bunch of tools that we think that novice users can pick up quite quickly and integrate within what they do in terms of improvement, risk and safety work as such. The idea around the teaching pack would be a lot of what you'll be introduced to today. We'll have facilitators notes with it. We'll have ideas for doing group work or other similar exercises. And ultimately, we would host it on the Turas Learn site, educational platform. In order to protect it slightly, we thought about putting it on our online hub. But you know, then it's open to the whole world as such. But if we put it on the Turas Learn website and also on the Q Special Interest Group for Human Factors site as well, it's kind of protected. But the right people can get access to it. I think somebody's got a camera on, sorry, a microphone on. Thanks. For those of you who don't know about the Human Factors Network that we have in Scotland, and I can see a few of you are online, which is great, who are members, please visit our online hub. We're on social media, on X or Twitter. And if you want to join the network, then there's the email address there, and we can follow up with you on that, if that is the case. So feel free to engage with us. So there's some learning outcomes. I won't go into many detail, but again, when we do the teaching pack, we'll align all the activities with these learning outcomes for you. So here's what the content of the session, the proposed content of the session. It's not today necessarily, but the teaching pack can be hugely flexible. So you can take aspects of it for maybe half hour, or like today, we could run a 90-minute to a 2-hour session, or you could expand it into a half-day workshop or even a full-day workshop. And so there'll be additional materials and additional facilitators notes within the pack so that you can mix and match. But the key issue here is that the initial set of PowerPoint slides that we'll introduce will be generic enough. And we wouldn't like them to be changed as such, maybe added to perhaps, but in terms of the key messaging that comes out of it and the facilitators notes that underpin it, we want this to be particularly consistent. As you will see later, we have quite a significant problem in health and care around our understanding of human factors, which is why they were doing this teaching pack. It's a big reason for it as such. So what is human factors? That's what we'll cover, what it's not. And then we're going to introduce you a whole bunch of concepts and tools very quickly. A couple of them we'll do group work with for 10-12 minutes. The rest of it we'll just have open discussion. I think there's an individual exercise. We'll send you away for 5 minutes on your own and then come back. And then we'll just share with, we won't be breaking around everybody, but we'll just ask for volunteers, or I'll pick on somebody that I know as a way to get some feedback on whatever it is we've introduced. So these are the concepts and tools that we've made a determination that can be picked up quite easily by novice users and applied, as I said, without much training as such. And then at the end, we'll speak about the teaching pack if we've got time. Really keen to know, for those of you who are interested. We're still kind of, it's in the final stages of development, so there's still room for folks to be involved in that if they wish, or you might be keen to test it as soon as possible, and that would be great also as well. So first bit of interaction, I suppose, so you can either put your hand up here or just post away in the chat. What I'm looking for is your current understanding of what of human factors. What springs to mind when you hear that term? What words automatically form at the front of your mind as a way of explaining what you understand by human factors? Want to put your hand up, please do. Or just type away, as I said. Karen's saying anything that impacts on performance. Anybody want to add to that? Looking at people in context, making it easier to do the right thing in work. Great. So we've got performance, we've got context, making things easier, how people interact with an environment and the outcomes that leads to it. To prevent human error, we'll come to that one, Louise. Understanding the system, involvement in the process, the interplay of structures and dynamics. I like that. So understanding the impact of humans on work and life. Thanks, Megan. How humans feel and react to work changes and outcomes. Thanks, Mimi. Okay, that's great. Thanks very much, folks. So that's given us some insights into what your current understanding is. So keep that in mind, and we'll revisit that after we do the brief introduction. So I'd like to start with this slide and break it down. So we've got there the really boring policy definition agreed worldwide of what human factors is. And I like to break that definition down because it tells us a lot of what the purpose of, what the approach is and what the purpose is of human factors. So the first learning point for those of you who didn't know is in that definition there, you can see ergonomics and then in bracket or human factors. So it's widely accepted that ergonomics and human factors is the same science and the same profession. It has a historical and geographical difference. So generally speaking, if you're in North America, you tend to use the term human factors. The rest of the world tends to use the term ergonomics. But what we find in the last couple of decades is that most places use both interchangeably as a way of acknowledging, the historical and geographical differences. So key first learning point is that human factors and ergonomics is the same science and the same profession. It's concerned with the understanding of interactions among humans and other elements of a system. The reason I pick up on that is there isn't a day goes by, and you may have heard me say this before, there isn't a day goes by where somebody will say to me, probably quite rightly complaining about an aspect of work, where they will say, it's a system problem, Paul. It really is a system issue. And what I pick up from that straight away is that they are divorcing themselves from the system that they're speaking about. So it's as if the system is something that's abstract, that sits over there, and this individual's here. So from the human factors perspective, as we see when we'll introduce social technical models later, from the human factors perspective, people sit at the centre of all work systems. They are the key component of a work system. They cannot be divorced from it. And they're also the most adaptable element of the work system, especially in health and social care, as we will see as well. And then if we get to the end of that definition, we can see what the purpose is of human factors. And it's to jointly optimise both human well-being and system performance. What is known as the twin aims of human factors. So any type of work improvement project that we're involved in, we are focusing on the twin aims. We'll talk about single aims later, which is maybe the pursuit of other disciplines, like, for example, quality improvement or risk assessment. And this is where potentially we can integrate human factors with these other disciplines and these other approaches in a way to add value to what's been currently done. But it's great to see some of the attempts to define human factors in the chat, because I think a few of you picked up on the simpler definition there, which is designing for people to make things easier, safer, and more efficient. So in some respects, you could argue that human factors is not about people. That might sound contradictory. It's about designing for people. It's about making things easier for people. Yes, we need to know about people's capabilities and limitations, both physically and cognitively. We need to know that information, but we need to know that so that we can design things for them and that make it easier and safer and efficient and so on. Now, you'll recognise yourself, hopefully, in one of these groups here on this slide. So there are lots of people in healthcare and social care who've got a vested interest in improving human work. Okay. Now, we don't have very many human factors specialists, unfortunately, especially in Scotland. We're seeing a rise in NHS trusts in England beginning to employ human factors specialists, but we even have probably 4 or 5 different organisations who have a head of human factors. They have a qualified chartered professional now within their healthcare organisations down south, which is fantastic to see. But Helen and I are both working in the world of academia as well, and a good few MSc courses, postgraduate certificate courses now. So we're beginning to see a churn of folks like yourself going through these types of courses, which is fantastic, because that's a positive achievement. And some of you have been there already, and I know that, and we obviously very much welcome that. But what we'd love to see ultimately is some type of policy lever around this, so that it's not been done from the bottom up. But that's a debate for another day. So all these different groups have a vested interest in improving human work. But what's the distinguishing feature of human factors? What is different from what's currently ongoing to what human factors specialists would do in that regard? So these are what is known as the distinguishing features of human factors. I'm going to break it down into 3 areas. So I'll start with the third one first. I've already mentioned that. It always focuses on these 2 closely related outcomes of performance and well-being. Okay? And it's a term we know is jointly optimising them. And again, we'll unpack that later. I know that the word or the term systems approach is probably widely used in healthcare. You'll recognise it. You know, if you're an improver, you'll think about a systems approach. But in the human factors mind, they have a very different perspective on what we mean by a systems approach. And again, we'll both unpack the theory behind that and introduce you to a few tools that actually force you to take a systems approach to problem solving, to redesign, and to improvement, and so on. And number 2, it's always design driven. And this is a feature that is quite distinct from the human factors point of view. So if you do academic training in human factors, you will learn a lot about international standards, British standards, codes of practice around the design of interfaces, the built environment, and so on and so forth. And so we need to know about this, take account of human characteristics, their needs, their preferences, their capabilities, and so on. And we apply that to the design of, as you'll see in a minute, the design of products and services and work systems. So this is the systems approach. This is a theoretical overview of what we mean by a systems approach. So to use the fancy academic term in human factors, we're all about complex socio-technical systems. I'm going to focus on the one on the right, so the SEEPS framework. It's known as the Systems Engineering Initiative for Patient Safety. You'll see later that NES has arrogantly renamed it because we want to be inclusive to health and care, and we don't want to focus solely on patient safety as an outcome, but we'll come to that later. So this framework is generic. Okay? It can be used in absolutely any care setting, right? So you can think about it in a theatre, a busy ED, a general practice, a dental practice, a waiting room, a clinic, wherever. All of these different settings have generic features. They've got people in them, as we can see in the centre of that bubble. And the people might be staff, might be patients, might be family members. They're interacting with each other. So human factors is all about interactions, we saw in the definition. They're interacting with each other, and when they're interacting with each other, they're normally undertaking tasks, okay? They're doing things. And when they're interacting with each other and undertaking tasks, they're usually using technology of some sort, okay? So there's 3 interactions taking place. And when they're using that technology is usually situated within a physical environment. So the physical environment has a role on both performance and well-being as well. So that's 4 interactions that are taking place. And then the 5th one is the organisational factors. And by that, we're talking about how work is governed, how work is ruled. So you can think about shift work patterns, leadership, teamwork and communication, culture, all are influential in terms of the interactions taking place with the other system elements and how they influence the outcomes on the right-hand side of this diagram. So you can see the outcomes there, which are essentially just a mirror of those twin aims. Okay, so these interactions, when forced, when we do the work, we force these interactions, and they give rise to outcomes on the right-hand side that we're either trying to achieve, like safer care, or trying to avoid, I don't know, work-related stress or burnout in the workforce. Okay, so this is where it becomes a bit of a mind meld for some folk, because what essentially this model is saying to you, okay, so it's dynamic, it's emergent, it's complex, there's feedback loops there. What this model is saying to you is that things go right for the same reasons they go wrong. Okay, so when things go wrong, the outcome is catastrophic, often, or unwanted, at least, not nice, not desirable. The outcome is, but the process of getting there is often just an illustration of these normal interactions that take place that have been described here. So what we call normal everyday work. So that's why we say the term, you know, things go right for the same reasons they go wrong. Now that's a leap that is quite difficult for some to make, and you know, it's saying the opposite of what linear cause and effect approaches are saying, which we're often saddled with in news in healthcare, which are quite reductionist. So this is about emergence, really. This is saying to you that outcomes, both wanted and unwanted, emerge out of the interactions that take place within this model. So knowing the theory of this helps us as improvers to rethink the dynamic complexities that we deal with in everyday work when we're trying to improve it in some way, whatever approach that you're taking. Hopefully we can unpack this in easier, but that's the kind of academic theory that we're over with. So going back to the design nature of human factors, it draws on, so it's a mongrel science, okay? So it draws on many other sciences, especially from the human sciences. So anatomy, physiology, anthropometrics, sociology, user experience. Okay, so we take these principles, these approaches, the evidence from these other scientific disciplines, and we apply them to the human-centered design of work tasks and work systems and technologies and so on. And we try and achieve those twin aims on the right-hand side. Very quickly, so anthropometrics is the science of body measurement, and that came to the fore quite acutely at the beginning of the pandemic, when we could see straight away that PPE, where we could get our hands on it, is essentially designed for men and not for females as such. So that has impacts, that has consequences, and we can see the same when we look at, for example, surgery. That most surgical instruments are designed for the hands of men and not for women. And that has also consequences in terms of female surgeons having to adopt awkward postures, and you know, the risk of musculoskeletal disease goes up with that, and also the risk of things going wrong potentially as a result of that. So this shows you the consequences of suboptimal design when we don't take account of the users of instruments or technologies or work systems and the potential impacts that can have. So anything that irritates you, frustrates you, causes you a hassle, okay, is a risk, is a major safety concern. Anything that you identify in those brackets is a human factors issue, okay? And it's worthy of a human factors analysis and a human factors design solution. So we can see there lots of big ticket areas where human factors in healthcare has had a role, but unfortunately, the vast majority of what you're seeing there is been from a research perspective. So we'll see healthcare organisations working with universities and their human factors teams, which is great. But what we really need is embedded human factors specialists at the sharp end of practice in health and care. And as I said earlier, we're beginning to see that in dribs and drabs, which is great, but we need much more of it. So human factors is about improving all aspects of human work. So if you're in a hospital, everybody from the car park attendant to the board chair and everybody in between, they're all doing some form of human work, and human factors is interested in supporting their performance and protecting their well-being. I hinted earlier about some of the problems that we have in healthcare, and we have to address this. So generally speaking, and I don't want to be controversial here, but I would put my mortgage on that what I'm about to say is reasonably factual. But generally speaking, anything that you read about human factors in healthcare in a policy document, in guidance, or published in the literature will generally have the wrong idea about what human factors is and how it's explained in that documentation. So there are a number of fallacies, a number of myths, a number of misunderstandings which continuously circulate. So I can go back to 1989 in the BMJ when they spoke about human factors in an article and got it wrong immediately. And I can show you the timeline all the way where that article's been cited and adapted and copied and published in many other documents. And the wrong message has just continually been circulated throughout that. And what do I mean by some of the wrong messages? Well, people think about human factors as being factors of the human, what your values are, what your beliefs are. We're not necessarily interested, human factors specialists, in getting inside your head. That's the job of psychology and even educators. As I said, we're interested in designing for you. It's not a cause of failure, and it cannot be conflated with team training and non-technical skills training. And that's the biggie. So folks who, for example, we're doing human factors training, what they really mean is they're doing non-technical skills training. Now, non-technical skills training is just training as far as a human factors specialist is concerned. It's just what you should be training for as part of your job. It's not human factors. It might be addressing human factors issues. So you might be getting trained in communication or teamwork or leadership, because these are seen as suboptimal. And that training is the intervention there. So from a human factors perspective, we would agree that communication or information transfer, we prefer that term, is a human factors issue, but training might be just part of the intervention. What we really need to do is understand from a systems perspective, what are the issues which are influencing team performance? So just to jump to the fact that we need to train everybody in teamwork is not a human factors approach. So it's in the literature, it's often conflated wrongly with training and non-technical skills and so on and so forth. A few times it's conflated with QI, but I think there's potential for some brilliant synergy there between human factors and QI, and we'll see that later. So I said about fallacies as well. So we don't teach people to modify their behaviour. So essentially, human factors as a science is about 80 years old. It was born as a result of the failure of behavioural interventions in work systems. So telling people to remember what to do X, Y, and Z, or whatever the case may be, and change your behaviour or be better behaved, it's not a human factors approach. We're looking at designing work to get the behaviours that we're essentially trying to look at. So it's the opposite way of thinking. I think I saw a mention of human error in the chat earlier. So we cannot eliminate human error in the vast majority of circumstances. We need to accept that it's inevitable, and that's a struggle for some. Some folks need to unlearn what they think they know about human error or medical error as such. What we're trying to do is design technology, design work systems which accommodate the inevitability of error and dampen its impacts, what is known as resilience, okay, to make work systems or tasks resilient to the inevitability that somebody's going to do something wrong at some stage. But can we stop it being potentially catastrophic as whatever? So that's a different mindset, a different way of thinking, very difficult to do. Yes, there are some forcing functions we can put in place that just completely mitigate error and control it. That's great, but there's very, very few circumstances where that happens. We're not just focusing on individuals. There is nothing commonsensical about anything that happens in the most complex work system that has ever existed, and that's the one that you inherit. Okay, so we might talk about common sense, but the minute you think you've got a simple common sense solution and put it in a complex system, it automatically becomes a complex intervention. I don't think we know enough of that about that, and it's really important as improvers to know about that. I kind of disagree with the last point there, number 5, because what we're doing is, we're saying here that we a couple of hours or maybe even a couple of days training in foundational human factors theory and basic concepts, then we think that novice users can pick up this and add it to what they're already doing. The ideal would be to have, professional ergonomists or human factors specialists at some point in the future. But it's why we're doing this, because we're closing a gap here in terms of knowledge and skill, which we think, as I said, folks like yourself and others can pick up and apply. Just very quickly on language. Now this is what I do personally. When people talk about human factors are, no, human factors is, okay? So it's not a collection of factors about humans. Human factors is a science. Human factors is a profession. So if you've got a problem in the workplace, so I like to say, well, it's a human factors challenge, or it's a human factors issue you've identified, or it's a human factors problem. We don't do methodologies. So for the QI college, well, we have a QI method, it's QI methods. QI is the methodology. So it's about sorting out our language and being precise in our understanding and what we're meaning here. And if we're going to design something, some sort of improvement intervention based on human factors, then it would be an intervention, or it would be a potential solution. So I'm just trying to get the way we speak to each other ironed out, so there's a consistent understanding and a consistent approach, a shared understanding around the language that's been used here. And that's a big part of the problem that I said earlier about what's in the literature. Okay, so that was a rapid, high-level introduction to human factors and ergonomics. Just keen to know if you want to put your hand up or put something in the chat. But is that a bit of a surprise to some of you? Did some of you think it was something else? Or I'm all right. I think I kind of knew all that anyway. So I'm pretty consistent with that. Helen.
I was just wanting to say two things, right, you know, sort of related to all of that. So the first one was about this idea of errors. The errors anyway, even if people do make errors, they might not really be errors. That's a decision someone makes. It's a perspective through which they view it. And I would say that's the single biggest impact I've had in the 3 years I've been at Aberdeen, is now everyone talks about errors in inverted commas. So that's about as effective as that's been. But the second one that was interesting, where we were talking about quite a bit of talk in the chat there about design, you know, so like football boots being designed for men that women are having to wear, and that's why women are ending up with a lot of I think it's the knee injuries, isn't it, that particular problem. But people are talking about sort of biases. I think all it is, it's simpler than that. I think it's just that so much of what happens in design of health systems is actually invisible to us. We don't know our heritage, if you know what I mean, in terms of where so much of what we do has really come from. And so of course a lot of this is invisible to us, and working with all stakeholders and identifying those stakeholders is why human factors is such a good thing to do, because it starts to address some of those equality, diversity and inclusion issues as well. And I know all organisations will be having issues with those right now. So that was all I wanted to say.
Thanks very much, Helen. Yeah, I've eviscerated the term error from my vocabulary as much as possible. The reason I do that is because the vast majority of the times that the term is written or spoken about in healthcare, it's used wrongly. So we'll see things like, oh, there's been an error. And I'll say, well, how do you know there's been an error? Well, because the patient's harmed. Okay, right, so the patient's harmed. So there's been a harm incident. It may or may not have involved an error. We don't know that yet. So the vast majority of really complex, serious incidents that happen in healthcare, when you analyse them, there is no circumstance there where you can see a conventional definition of a human error that's taken place. We know what the outcome is. We're trying to get to grips with how it actually happened. But the term error is not helpful in that sense, because everybody seems to have done what they were supposed to do. So nobody's, you know, as far as we can tell, nobody's made an error in the classic sense. So, you know, we conflate these terms all the time. We misuse them. So for me, the unit of analysis is the outcome, which is the safety incident or the harm event as such. So that's something I think that we've got a learning need around is a use of terminology. Another hand up there, thanks. Mimi, thank you.
Yeah, no, I just want to say I'm really enjoying it. And yeah, a lot of it's familiar, but I'd have to be a complete idiot if I should say it was all, you know, you think some about more of it than other things. There's just a couple of things that what your perspective on. Some of it is common sense, but in actual fact, it's really, really difficult. But I wondered what your thoughts are on sort of like the power dynamic, because some things seem quite obvious, but powerful people get in the way of doing what should be the right thing. And I think in some of the work I've done, the historical context, so the right people can do the same things in the same way and get a different outcome because there's been something in the past, perhaps, that's, I don't know, maybe your community anger, or so you can't change. So there's some human dimensions in this. I was just wondering, do you agree with that? And does this approach tackle that?
Of course, absolutely, of course. I don't know how to tackle it. So I've got kind of equivalent experiences. I know this has been recorded, so I need to be careful what I say. So I've been involved as Scotland's representative, for example, in the development of the patient safety syllabus. And I wore two hats there. I wore my professional hat and also my NES hat. And so I represented about 50 human factors specialists who work in healthcare. I've got experience in healthcare. And we, as a consensus, put together, well, what the human factors perspective on this syllabus was be, in a very helpful way, because there was an open consultation. We did it 3 times, it was ignored. And so the syllabus is a great step in the right direction, and human factors is included in it. But in our professional opinion, it's completely muddled. It's like a jigsaw piece puzzle. It's all there, but it's all jumbled up where it doesn't have to be. The point I'm making there, Mamie, is your point about power dynamics. So, so that what we were involved in was an example of medical hubris. Very senior people who are involved know better than you do, and therefore this is the way we should do it. And your professional opinion is just your opinion. Such, so there's a kind of belittling aspect of that. Now, that's just one example of many that I and others have been involved in. So what's the human factors take on that? I'm unsure, because it's a very behavioural issue as such. Recruitment and selection is something that we can potentially do around that, but that would be a long time coming. Helen, sorry. Thanks, Mamie.
No, just following up on that. So of course, across England now, these patient safety specialists have kind of come into post and are being trained, and it's in response to that National Patient Safety Syllabus. And it's really interesting to see who are the people that have been, I don't know if selection is the right term, but it's been selected by their organisations to be these patient safety specialists, because I think a lot of them are actually in roles where, and they all talk about being bands, so they're all band 7. There's a lot of nurses, there's not very many doctors, and it's quite interesting thinking about the actual range of kind of power, if you like, of these patient safety specialists. Some of them I think will get listened to in their organisations, but others might well not, because of that power dynamic that you talk about. So human factors would definitely discuss that, would definitely see that as one of those. It's probably a person factor, probably an organisational factor, it's probably an external factor. I mean, we quite often see in the medical school, when we interview students, we say, care's delivered through a multidisciplinary team. Why do you want to be the doctor? And they quite often come back with things like, well, because the doctor's in charge, or the doctor knows the most, those sort of things. But that's come from somewhere, I mean, they weren't born thinking that, so that they must all be being imprinted with this kind of medical and clinical hierarchy before they get anywhere near the medical school. So those are just things that we need to think about. And even if we can't do anything about them right now, at least we're, it's something there that we know we need to work on. Thanks, Paul.
Thanks very much, Helen. Hi, Angela, please come in.
Hello, Paul. Thank you for that. That has been really interesting, and it has made me reflect actually on human factors, and I suppose the historical aspects of the health service, and where that's come from, and the design element. Just I think Helen and Mamie were talking about that in the chat, and about, I suppose if you have a hierarchical structure, it's mainly run by white men, say white middle class men, and those links to the design element of instruments, that's really fascinating actually, and just how things are done as well, I suppose. So that's made me think about that aspect of it too, and how we design better for a broader range of people who work within the health service, and social care as well.
Yeah, absolutely, Angela. Thanks for that.
Thank
yeah,
you.
so we're still buying technologies and products and services that harm people. We've got a long way to go. in terms of embedding human factors thinking and approaches in what I call the big ticket items, so like the built environment or in procurement, or in organisational learning, as such. So we've got, you know, a long way to go from that perspective, but we need to start somewhere. And in Scotland in the last 5 years, I think, you know, I can see Karen Cormick on the call as well, and Karen's part of the network. I think, Karen, would you say things have changed in the last decade or so from around the label of human factors and the amount of folks that are now involved and the approach has been taken and so on?
Yeah, I think it has improved. I think as you're right, we still have a long way to go, but I do think that it has improved, and I've seen like considering design as part of like adverse event reviews. We had an incident with a chest drain, and basically, you know, if the message was you need to remember with this design that you need to do that, and as soon as you have a message like you need to remember that it's not obvious, that there's something about it that's not obvious, that there's a trap there waiting for you that you need to remember not to do, then it's a bad design. So we changed the chest drain throughout the whole organisation because of that event, basically, that the wrong thing was done. And rather than sending out a memo saying to everybody, remember, I know it looks like it should go in there, but it doesn't. We changed the design. Yeah. So, but I think the problem is that we tolerate a lot of stuff that we know is poor design because we don't have time to do anything about it. So it's not until it's really bad that something changes.
Absolutely, Karen. And that was a brilliant example there of human factors in practice. So Karen's organisation there, you know, realised that what they were introducing was a behavioural intervention, which, as we said, don't work in complex systems, and then went down the design route. So almost coming up with a forcing function, if you like, which would be seen as an excellent example. Mimi, thank you.
I was interested in your opening comment, you know, where you said that people say it's not the humans, it's the system. And why I think that's quite interesting is that's often what patients say, you know, staff are working really hard, it's not them, it's the system. It's what the politicians say. So just wondering where that fits into all of this.
Well, it's just your definition of what we mean by a system. So from the human factors perspective, you know, so we're trying to communicate with each other just now. So that's a system. Okay, I'm trying my best to articulate and be interested and interact with you. So that's a form of a system that involves two people. But we're also, this conversation has been mediated through technology as well. So that's a different system. So the point we're making from the human factors perspective is, however you define a system, whether it's micro, meso, macro, whether it's complex, whether it's adaptive, whether it's social technical, people are always at the centre of it. You know, so to say it's a system issue as if you're divorced from it doesn't make sense, and that's really all we're saying there, Mimi. Helen, do you want to come back in?
Yes, sorry, I'm thinking before I go, I want to get as much as I can in. It's quite interesting. I did a kind of a revisit of all of the main patient safety, sort of, you know, national patient safety disasters, you know, right from Ely hospitals through to the sort of recent maternity scandals. And it was quite interesting in the earlier investigations. There was no mention of system. It was all about blaming the individual. And then gradually, you know, people started to think about everything that was around that individual. And then it seems to have gone right through and out the other side, almost gone too far, that people have gone to blaming the system without thinking that if I'm part of the system, then there is a responsibility to, you know, to start to try and address that, you know, those systems factors that improve performance. So I think that's one thing we do have to be quite wary of.
Yeah, thanks, Helen. That's great. Thanks very much so far, folks. I'm just going to move on. So this is the bit where I'm flying without wings because we've never done this before. And so for the next hour or so, we're just going to sheep dip you in a lot of different kind of concepts and tools that we have very quickly, and get some feedback. Now, you should have all been sent a whole load of materials in your emails. I'm just wondering if anybody's had time to very quickly go over the fact sheet. It's a very rough draft. It's a bit Mickey Mouse at this stage, but I'm just wondering if anybody's got any views on it. It's what its potential use could be. Is this you all drastically reading it now for the first time?
I can just say, Paul, I use it actually as the opening thing for whenever I'm actually introducing human factors to students. I always send them away with a task to look at a couple of papers that both purport to be about human factors. And then the students use that fact sheet to try and critique, because it's quite an effective way of bringing them to think about those differences.
That's a good example. Elaine's been very honest and said she's not had a chance to review it. That's absolutely fine, Elaine. So, Elaine, if you're getting bored, you're still on the call and you're getting bored with listening to me, you could maybe have a wee look at the rest of the stuff as well. Thanks very much. Karen?
Yeah, I think it's good and that it's very factual and it gives you all the information. But to be honest, I'm not sure that, like, for example, clinicians on the ground would read that level of detail. But I think the people who are doing the training on human factors need to know that information. So I think for a trainer, you need to know that background, but it's not something that I would go through in that level of detail at the training, if that makes sense.
Oh,
but you need to know it for questions and stuff like that, you know.
Perfect sense. That's the way I was thinking, Karen. I just, out of frustration last year, sometime just decided to amuse myself by writing down 10 things that you come up against quite often. And then, so I've done it and we just called it a fact sheet. I've never done anything with it, I don't think. So I'm just put it out there. How could we use this? And the most obvious one is it would be for those at the level who are doing the training, if you like, rather than those at the sharp end as such. Anybody else, any comments on that fact sheet at all? Okay, so hi, Barbara, please.
Hi, sorry, I'm absolutely completely new to human factors, so I feel quite overwhelmed today, actually, in the company that I'm sitting in. So for me, I really enjoyed the fact sheet. I thought it was a great starting point for me, actually, and it was a very quick run through bullet pointed list. So I found it very, very useful. So thank you.
Thank you so much, Barbara. And if you're overwhelmed at this stage, just wait until 2 o'clock. Okay. Helen Ross, sorry, do you mind talking to that comment you've just put in the chat, if you don't mind, please? I hate to doorstep you. It's quite an interesting one.
I'm in an airport in a...
Oh, sorry, Helen.
Cafe. Okay. No, it's fine. It's just I'm aware of the background. What really... I'm an OD professional, so I'm thinking of it through this lens. And what really strikes me about human factors is it sits in a different paradigm of thinking to what is embedded in how a lot of people in the system think and how the system's currently organized. So for me, in order for people to really start to root what human factors is, an underlying question is how we support that shift in thinking from the organization as machine to the living system perspective. So you used the word emergence earlier, which is it's beautifully expressed through how you've described human factors, but trying to support people to learn about emergence and living systems without detaching from it as other than me, if this makes sense, is a real challenge. And so people could inadvertently root the human factors principles in their existing frame of reference.
Yep, absolutely.
That's what I'm reflecting.
So one of the ways we're trying to do that, and there's a few on the call who are involved in the safety learning review work that's ongoing in Scotland just now. So there's a set of systems thinking principles I've got a slide on later on. And it's the systems thinking principles are an example of that. It's trying to simplify as best we can what is a philosophy or a mindset, a different way of thinking about how and why things go well and go wrong. And that's the mind shift that needs to take place. The mindset, the shift in mindset that needs to take place. And that's a perfect example, I think, of what you're talking about. It's extremely difficult to do. So I sat in another camp 10 years ago. Systems thinking doesn't come natural to me. It took me probably 2 or 3 years to unlearn what I thought I knew about how and why things go wrong as well. So everybody has to go on a journey. Some people get it naturally. It comes naturally to them. But when we get to that, if you're not on your flight yet, when we get to that slide, then this is where we try to explain really difficult but very necessary concepts like emergence which is the opposite of root cause as such. You know, it's the opposite of reductionism. Now, this is all very academic, but it's necessary in a practical level when we come to improve and learn about risk and safety and improvement in healthcare. Mimi, thanks.
This isn't about the science of human factors, but it's just something that struck me over my career. I've worked in different sectors in research and education, in conservation and health, always in trying to change things and improve things. And the one thing when I eventually ended up in health was everybody thinks they're special and they're different. But the one thing that was in common was human beings and human factors, and it was around the complexity of all these things, how you manage different things. So when you worked in healthcare, they thought it was completely different, but when you worked in conservation, it was completely different. And often in a change arena, it often felt like conflict resolution. Yeah. And it's just, if you don't walk across different systems, you probably do think you're unique, but I'm not sure that you are unique. Some of the outcomes might be, but not in terms of the processes.
So I think that the counter argument to that, Mimi, is that in having worked with the military, having worked with aviation, and with specialists in those areas who've came and worked in projects, so both my experience and theirs is undoubtedly healthcare is the most complex human work endeavour that's ever existed. There's nothing comparable with it. So it is an exceptional case, I would argue, and those others would argue, that, you know, that in terms of what's going on with patients and families, never mind the lack of, you know, purposeful design of technologies and workspaces and buildings and so on, and everything in between it, the different professional demarcations, it's just sheer complexity, you know, to the nth degree, and there's no other organisation to say it can compare to that. Karen?
Yeah, I was just going to say that we need to really make it easy for people to understand, and I think it can become quite academic, and so we need to kind of watch the language in that. Even, you know, I've changed all my training to include SEEPs now, but even the title of SEEPs is just, nobody remembers what it stands for. It's quite alien, you know, so it's, you know, I'm glad that you're saying that you're changing what it's called, because you know, I have to explain to everybody what SEEP stands for, and it's not easily to remember. So, and that's designed by human factors specialists. So I think we just need to remember the language.
Absolutely, Karen. Good, really good point. And we'll come to that later on. So we've got a new name for it, but it's no settled. It's just made it up. So you've got input into what we can call it if you want to make it even simpler. Helen.
Thanks. I think another really interesting part of this is the backdrop of diagnosis and cure, and the idea that cure is achievable or is a desired endpoint. So I think that legitimates unconsciously so many assumptions around linear cause and effect, and we've talked about hierarchy and position and all that kind of thing. So I'm really curious about how human factors is integrated with person-centered narrative and value-based health and care, and that wider context as well.
Thanks, Helen. So I would argue that human factors is the ultimate person-centered discipline. You know, that's what it's all about, essentially, is designing for people to help them with their performance and to protect their well-being. So that would be my counter to that, Helen, but thanks very much for raising it. Sorry, folks, I'm conscious of the time. Never done this before, but I'm flying by the seat of my pants, as you can probably see. If you've got time, so I'm going to give you 5 minutes or so. You can go and get a quick cuppa as well if you're able to. One of the things that you should have got is a human factors case report template. What we'd like you to do is to think about a human factors issue in your workplace, identify one, and what potential impacts or actual impacts is it having on performance, on well-being, and if you can think of something that needs to be done. It's just very, very basic stuff. So we've been testing this out in Ayrshire and Arran to get some really good feedback on it, and Helen uses it with our undergraduate medical students as well. What role it has, I've got no idea, because I know that Karen Cormack's going to ask me that, you know, so what's the purpose of this thing and why you do? And I absolutely get that. It's just another way, I think, of raising awareness of what human factors is and getting people to think about, you know, those twin aims of performance and well-being, and also in terms of identifying a problem as a human factors problem. That's its first, probably, educational point I would make. So if you can look that out from your email, have a wee think about it. You don't have to fill it in detail. You can maybe just think it through. Take 5 minutes on your own, and come back, and maybe get a cup of tea, and then come back at 1 o'clock. So you've got 6 minutes, and we'll see you then. We'll have a wee chat about what you've found. Thanks very much. We left it for you to do just a wee exercise as simple as possible, or as more difficult as you like. Anybody wish to volunteer to outline an example of a human factors issue that kind of irritates or frustrates them? Karen?
Yeah, so this is a kind of organisation one that we're just about to try and tackle. So it's about swallow screen in accident emergency, which is a test that they do for potential patients that have got a potential stroke to decide whether they should be nil by mouth, because obviously they could have a problem with that. So the key issues with it is time constraints, because it's meant to be done within a particular time frame. The task allocation, so anybody can do it, but nobody does. The knowledge of how to do it is in question. Does everybody know actually what to do? The access of the equipment to do it. So is it readily available? Is it easily available in every bay, etc.? And there might be some people think, is it really necessary? Do we really need to do this? So there's quite a lot of stuff to sort out. And the impacts are, obviously, you could have a patient choking, and also that we collect these stats. So we are kind of questioned about whether we are meeting this target. So it is a target as well for us to look at. And we are about to kick off some targeted improvement work to look at all these elements.
Brilliant example, Karen. So I'm delighted that you picked one with a kind of certain level of complexity about it, because I just assumed people would pick something really simple, like the coffee machine doesn't work or whatever. Karen, I'm curious to know, not the way that sheet looks just now, but I'm curious to know whether you as an organisational leader think there's merit in exploring the idea of highlighting human factors issues in some sort of mechanism to do that, or do you think it's already covered? Yeah,
no, I actually really like the sheet. So I thought it was really helpful, and I thought it was helpful having the kind of grey boxes there as a kind of check. It's a bit like the Yorkshire Contributory Framework, where you've just got a kind of aid memoir to remind you about, could this be an issue? Could that be an issue? So I really liked that was with the form, and you're not having to go and find that somewhere separate. So I thought that was helpful, and I thought that the questions were quite helpful to make you think about, so what is the aspects of this that could actually be the problem? So it's kind of forcing you to kind of break that down into chunks. So I thought it was really good.
Thanks very much, Karen, because the Ayrshire guys, the risk and safety people, are testing it just now, and they like it as well, but they come back with some feedback around, can we neutralise the questions, because they couldn't help, as well as picking up things that are risky or whatever, they couldn't help but see examples of good design as well, which they were noting down. So I thought that was interesting. So I'm trying to think of a form of words to kind of neutralise it, and but still capture the same stuff, but also the sharing of good practice as well, possibly. Anybody else? Mimi, you've got an example you said from a previous work role. Are you up for sharing that, please?
Yeah, okay, I'll give it a go. So this one, and it's still topical to this day, but it was dealing with long waiting times in emergency departments. It was having whole system impacts. In other words, people waiting a long time, couldn't get admitted to hospital, can't get out the home. And what we were told to do is we need to reduce waiting times. So that was kind of the straightforward thing. The reality was, in terms of this, was that the clinician said actually nobody waited more than 4 hours. Their analysis was that if we tried to impose something like that, people would die and that the system would be worse. And confronted with that, what needs to be done was to try and get everyone together to understand, why is this target being introduced? What's the evidence? What's the leadership? And how are we going to progress it? And using sort of small cycles of change. So that was at an individual health board level, but it was also a national challenge.
Excellent example, Mimi. Thanks very much for that. Anybody else want to quickly share? Hi, Lynette, long time no see.
Hi, Paul. I think I had an individual example around record keeping on pressure ulcers in district nursing, but actually I think record keeping across whatever IT system that we buy in the NHS, we don't necessarily think about the whole system, so we only think about the specialty that we work in, and then realise that that information isn't shared with the other specialties information. So there's quite a lot have come up over serious adverse event reviews over the years. It just comes up time and time again on the systems that we use, and we don't give time to people or the equipment to be able to update that before they see the patient necessarily, particularly within the community.
Yeah, another good example. Thanks very much indeed, Lynette, for sharing that. Angela's posted a comment about the potential use of this in looking at reviewing adverse events. So Angela, you're absolutely spot on, but we've got another very similar tool, because what you'll probably see here is I've taken that SEEPS framework and divided it up into about 10 different uses. So what we're calling the Swiss Army knife of human factors. So yes, you're spot on. We will be. You'll come to that later on. So again, another small intervention that we believe could be applied by individuals, novice users around human factors to highlight ergonomic issues in the workplace and articulate what impacts they're having or could potentially have. How we use it, how it's implemented, how it's sustained, get no idea. It was just a question of trying to see, can we capture this type of stuff at this moment in time? I mean, I know that we obviously report via our Datex and similar systems incidents or near misses or whatever. This is slightly, it's overlapping, but it's also slightly different. So it's just something to think about, and for us as well. So thank you very much for your engagement with that. SEEPS, I hate the term as well. Because I hang about in rarefied circles sometimes, I know Pascal Carillon, who was the originator of SEEPS, and I've tried to persuade her over the years, unsuccessfully, to change its name, because the focus on patient safety is kind of misleading, because it's a system analysis tool, so it can be used for any outcome whatsoever. And that's what we've tried to do at NEST in the last decade when we get into this, is to make this as generic as possible. So I said it's a Swiss Army knife of human factors. It's the one thing that I think as a community in the UK we've agreed that we should introduce in a generic sense to health and care, because we think it's relatively straightforward to pick up, and it's got that multifunctional purpose. It can be applied for a whole range of different issues there. And we're already seeing it being used in simulation. We're already being seen in safety investigation. We're already seeing it being used in quality improvement, which is fantastic. And also the design of work procedures as well. I'm going to introduce you to walkthrough analysis later as well, and it's incorporated within that. Give me a second. So at this moment in time, and we'll call it whatever we as a community decide to call it, but I've just called it CAST just now. So the care analysis, our care system analysis tool, doesn't even rhyme with it. But anyway, so this is a generic worksheet, and I think Helen Ross mentioned earlier about this way of thinking and trying to simplify it. You know, the whole idea of emergence and so on, all the fancy academic stuff. So you can take any problem. We're going to practice this in a minute in groups. You take any problem whatsoever and think about it systemically, and think about the interactions that take place between these different system elements in a particular care process, whatever that care process is, and how it's leading to these outcomes on the right-hand side that you're either trying to achieve or you're trying to avoid. So one of the ways that you can use this is to say, right, how can we design a care system to get the outcomes that we want to achieve, and define what we mean by the outcomes on the right-hand side there. Or you can flip it in its head. So what are the facilitators, or what are the barriers? You can use it both ways. Now, I've seen this, I've had half a dozen consultant staff say to me that they've used this tool. So another way it can be used is to tell a system story. So that if you want to go to an executive team, you know, a board meeting, and you're trying to articulate and visualize a particular problem and the impacts it's having, then they can use something like this graphic here to do that, and show folks what the different interactions are taking place and what this is leading to or potentially leading to. On the flip side of it, there's a piece of guidance there, just trying to simplify it, how it can be used, what the various guidance steps are, and then again, examples of these what we call PIFs, performance influencing factors, the thing that Karen mentioned earlier. So it's just there, you know, to prompt you to think about them. as such. So we need to rethink about a different name for this. Absolutely get that. But the basis of a worksheet and a way of thinking and a way of doing, I think, is intact. You know, it's fairly straightforward. And I said we haven't promoted it a lot in years, but we know that it is widely used. Yeah, I thought about that. Yeah, Karen, system analysis tool. That was on the list. Thanks. Okay, so Agatha, I think I'm just going to prompt you. I think we're going to go into some small group work for 10, 12 minutes. I think everybody, if we just look at group exercise 2 there. So what we'd like you to do is something generic, okay? Identify what system elements should be designed to enhance hand hygiene compliance in any care setting that you wish to think of. So what performance and wellbeing outcomes, forget about the avoid bit, what are you trying to achieve, okay? So how would you design a care system to make it easier for clinicians and others to undertake hand hygiene tasks as such? Does that make sense? Right, seen a few nods. So group exercise 2, I don't know if you want to take a wee note of that, a wee photograph, because we're going to use we'll probably lose the slide when we go into the group work. But Agatha is going to apply the magic and stick you into small group work sessions just now, and then we'll see you in 12 minutes. So you get a 10-second countdown. She's been voluntold to feed back some of the issues that we picked up on. Do you mind, Lynn?
Not at all. So yeah, we spoke about a number of issues around things like the environment in terms of, you know, where the sink is and the soap is and where the hand dryer is. We spoke about what's the evidence base for the intervention, and actually do people believe that hand hygiene is a good thing, or do they believe the evidence base for the harm that might be caused if you don't? So there's maybe some cultural things there. We spoke about, Ricky in our group had mentioned how, you know, issues with allergies, particularly with hand hygiene, and you know, I'd kind of used the example where, you know, I remember everyone's hands were becoming really chapped and trashed because of the frequency of hand washing, and we were all given hand cream, and you wonder whether, you know, was that the right actual solution in terms of that problem, or was it just a frequency problem, or was that particular hand soap particularly harsh on your hands? So, you know, that could have potentially brought up a design issue there. We spoke about things like, you know, policies, how that might impact it, to say the environment, training, people realising the reason for it. I don't know if anyone else in the group wants to come in if there's anything that I've missed, because I wasn't jotting it down.
Yeah, Lynn, I would just add to that things like, you know, external issues around the evidence base, as we've said.
Yeah.
There might be a national policy, that's external. There might be an organisational policy issue, standard operating procedures. You look at the people issues, there might be training, and there might be differences in values and perceptions, behaviours around this as well. So lots to contend with. So thanks very much indeed, Lynn. Does anybody else just want to add anything that Lynn's group maybe didn't pick up as such?
Just mentioned about competing priorities, that, you know, you might be getting somebody policing you for not washing your hands, but actually there's no hospital beds, so the whole system's in chaos, and that's sort of almost like clutching at straws. Yeah,
really good point, Mimi. So that's, as we said earlier, that's a goal conflict you find yourself caught in, and then you have to make a trade-off between trying to be as safe as possible, but also as efficient as possible. And these are the sort of things that, you know, clinicians at the sharp end of practice have to manage every day as such. So the hand hygiene one plays into that example as well. Thanks, Mimi. Anybody from any of the other groups just want to add their tuppence worth over and above what you've heard so far? Hi, Sarah.
Hello. So we mentioned quite a lot of those things as well in our wee group. We also spoke about the physical environment and the variability of those across health and social care. So what you'd expect from an environment in a theatre department, for example, with the time that's allocated to scrub up and wash your hands, and the availability of your soap and your towels and things compared to someone's home. if you're out there in the community or in a care home, variable levels of access to sinks and hot water and practical things, but also the consideration of you're in someone's personal space when you're in somebody's house, and actually that permission to be able to go into that room to wash your hands might not be there. So it's understanding the environment that you're in from that perspective. Yeah. And then we spoke about external influences being, be it a hospital or care home or independent practice, and the influence on external scrutiny, either be it a HIS inspection, a care inspectorate inspection, and actually how that impacts on organisational I suppose focus and leadership and role modelling and what does that look like? And we spoke a little bit about an example where somebody in the group said that they were doing a medicine, they looked at medicines errors, and it was a trolley, and there were several medicines incidents. The member of staff was actually going to find hand gel in between each patient's drug administration, and actually that inability to do the hand hygiene actually led on to more increased medicines errors. And that's, I suppose, like the system of hand hygiene and infection control and the system of medicines safety actually step back, and one's actually affecting the other, and trying to improve one area in the standards actually is having an unintended consequence on another area of safety. And that's an example of how the system all comes together. So that was a really useful conversation we had.
Yeah, brilliant example, Sarah, brilliant example. And it reminded me, because maybe in our group, the very first thing that she contributed was, and you were kind of hinting at it there, is that they wouldn't necessarily go away and use this worksheet. You would go and do some sort of walkthrough analysis of the site and observe what was happening first and collect data that way as a way to inform what potential design might look like in the future. So that would be a first step. And I think that type of unintended consequences has got the potential to be picked up using that approach, Sarah, as well. Any other final comments at all on that you'd like to add? Anybody get anything else? I only counted to 3 there in my head, so I'll take that as a no. Hopefully, the key issue here obviously wasn't hand hygiene compliance. The key issue here is that here's a worksheet that allows you to take a systems analysis approach to any given problem, whatever it may be, or to any given potential design issue, or to, for example, to an improvement intervention. What do you have to think about? We're going to do a bit of quality improvement in a particular area. Can we use this holistic system analysis approach to think through what the design of this intervention is going to look like, and what potential interactions are going to take place if we dump it in the system? And what do we have to think about in that sense? So it can be used as both a barrier, a facilitator in that respect as well. So Ness has got some good guidance on this, which we can publish quite quickly. The worksheet's been around, it's on our hub, or a variation of it's been around as well. We'll think through a new title for it, because we're trying to, as I say, share this high and wide across health and care. Just out of curiosity, Karen aside, because I know you've used it, has anybody else, number one, heard of this or used it? Yeah, Sarah, that's great, thanks. Can you remember how you used it?
So, sorry, meet my lunch.
No, you're fine.
I'm actually just towards the end of the first year of the MSc of Patient Safety and Human Factors with University of Edinburgh, and so I've actually heard some of your work before through that. So a lot of my recent studies have been using stews and seeps and things, so it's quite fresh in my mind, so I have to be honest.
Stews and seeps, Sarah, yeah. So stew cards isn't something I've introduced today, but we could quite easily have done that as well. Thanks. Mimi?
It might be something you'll touch on at the end, but one of the things I often hear is that there are lots of different approaches out there, whether it's the IHI improvement model, Scottish approach to service redesign, lean improvement, and it's, which ones do you use, or is it just about sticking to one model? But this one seems to have bits of that, bit more.
Yeah, so I mean, I don't want to get all academic and boring as such, but Karen was saying earlier about we need to simplify this as much as possible, and she's absolutely spot on. But academically, philosophically, methodologically, these approaches that we're introducing you to are different from what is traditionally taught in QI, for what I would call organizational QI methods or industrial QI methods. So things like Lean and Six Sigma, model for improvement. You can make an argument that they're useful in some respects, in some areas, but a lot of the times the best thing to think about is where did they originate? Well, they originated in manufacturing world, which is infinitely less complex than healthcare. And so the argument we would make is you need a different way of thinking and doing as such in healthcare because of that complexity. And so you're absolutely right, Mimi. There are plenty out there. It's horses for courses. But what we are suggesting here is for specific issues, especially around safety. I mean, we need to move our mindset. We need a different way of thinking and doing, and we'll come on to that as well. I'll tell you a wee story, right? So I've been in the service for, I don't know, 33, 34 years. So I was one of the first medical audit officers in Scotland, and I worked in Inverclyde Royal Hospital. I used to do dozens upon dozens of kind of audit stroke improvement projects with various care teams all over the hospital. And I used to go and meet them with my notepad and my pen and ask staff laddie questions to try and work out how we could design this improvement project and do complete the audit cycle and demonstrate improvement and so on and so forth. And I wasn't aware at that point, but subsequently about 15 years became aware of a technique known as walkthrough analysis and observation, which is fairly straightforward to do. Now, NES has produced this just recently, and it's already been taken up by the Healthcare Safety and Investigation Branch and NHS England's Patient Safety Team and recommended by them. So again, based on SEEPs, what we're saying to improvers is, well, if you're for example, if you're in a clinical area and you want to focus on some type of piece of work to improve, but you need to understand, as Mimi said earlier, you need to understand the nature of what's going on first. To understand the messy complexity, the reality of work before you actually design the intervention, because that will be useful for helping you to design whatever the improvement intervention would be. So this combination of walkthrough analysis and observation, so there's this guide here, the In Situ System Observation Guide, or ISOG, just gives you a series of prompts based on SEEPs that if you were walking through a clinical area, things to think about, questions to potentially ask that might not have been thought of before. So what it's given you, instead of what I did 30 years ago, was go in with a blank sheet of paper and a pen and half a brain, is this time you can go in with half a brain and a structure. So, a formatted structure, taking a systems approach to help you and the others think through what the nature of the issues are, which might impact on how you're going to come up with an improvement plan as such. So this is something that I strongly believe, how we do it, I don't know, but I strongly believe that anybody in particular who works in a risk, safety, governance, improvement, advisory role should be aware of this and should potentially practice this or something similar. And also, for those of you who are just clinicians or care practitioners who do improvement work, you can also use it. It can be used by anybody. It's fairly straightforward stuff. It's just there as a prompt. So I'm curious to know if anybody kind of takes this approach already or does something similar. Karen?
This would have been really helpful for me in the last 2 weeks. So I'm doing something about chance to check, which you're aware of, Paul, which is a mechanism to reduce medication administrations. But I was approached by the chemotherapy nurse leads to say, look, we're a wee bit different. Given chemotherapy is a wee bit different, it's a different environment, it's a different way of doing it. There's regulations we have to follow, etc. How would chance to check work for us? So I says, look, I'll come and do an observational audit. So that is exactly what I did. And this would have been really, really helpful because I was just kind of making it up. I was considering human factors in it, but I didn't even think to use SEEPs, which I should have done. I didn't have any particular tool that I was using for it, but I did pull out loads of human factors in relation to it and came up with different solutions that I thought I was going to at the beginning. It's a different problem, the chemotherapy one, rather than the same problem as for the ward administration incidents. But I think it's a really good tool.
Thanks very much, Karen, for sharing that. So I used it a few weeks ago as part of a Q-funded project. Actually, I had to go and visit a few hospitals in Merseyside, 3 different hospitals. I did 5 different site visits, and I was observing surgical ward rounds. And I used the tool not as part of what I was supposed to be there for, but I used it because straight away I noticed that the FY1s and 2s, the SHO and the Reg, the amount of hassles they were having with technology, with laptop stands, with the lack of physical room and side rooms and wards, tripping over stuff. So I just used this to note down 45 different human factors issues that impact on the performance of well-being of doctors in training on a surgical ward round, just to kind of prove a point and test the tool out as well. So N equals 1, and I think it really has the potential to work. Sanjeev, thanks.
Yeah, although we didn't use the tools, I've got a couple of examples. So there was COVID when we changed to a completely different system for a while. And part of that was doing walkthroughs of pathways around the hospital. So I work in critical care. So there was lots of transfers of patients in and out of critical care that we did walkthroughs for, and, you know, link routes of patients through ED and other areas. And the walkthroughs are incredibly useful. So we didn't use a template, a piece of paper like this to structure our outputs. We essentially designed our own, and given that lots of people have interests in QI and human factors, you end up with something that's not that far away from something like this. The other example is more recent, when we've changed the configuration of wards and we've got the short stay surgical ward and changed how theatres work. Again, walkthroughs there, and actually walkthroughs are becoming quite a regular way of trying to preempt, if you like, or try and pick up design system issues especially when we're making fairly radical changes. So they're incredibly useful. My reflection is that a template like this could actually make the outputs or the observations, the learning, more official, if you like. You know, actually, rather than this being a kind of here's a group of us taking a walkthrough and we think this, which has the risk of getting lost in any kind of design or process. But if you have an official output, it actually gives it a lot more strength. So I think having a template like SEEPS or this to work with, I think gives us actually more strength in trying to get design into some of our solutions. Because for me, it's not the analysis of the learning that's often the problem. It's often actually trying to implement decent solutions that's we fall down on.
Great, Sanjeev. Thanks very much for that. Yeah, so to me, it's just giving you that structure, giving you that formality, because you say, walkthrough analysis has existed forever. We may have not had the language to describe it in that sense, but we can also use observation as well. You know, you can pick things up. You can also capture multiple perspectives. You know, so you know what you get off a nurse, the doctor might have a different perception of what's going on, or even difference between groups of nurses. But it allows you to capture that and try and make some sort of nuanced sense of it.
Agreed. Yeah. One of the key things was having a range of people on those walkthroughs, actually, so it wasn't a unifocal perspective.
Yeah, brilliant. Yeah. So any other thanks, Sanjeev. Thanks, Karen. Any other comments on this, the potential, if you like, of this type of approach, or no? Okay, that's great. So you've been introduced it, so the job done. I'm not going to focus on this too much, other than this whole idea of a dynamic risk assessment. It's fairly straightforward, again, based on SEEPS. It's essentially, for those who work in risk, this is risk 101. Strong interest from our colleagues in general practice in Scotland and Wales and Australia, and is developing this as a tool in that setting. I know that folks who work in risk in hospitals, for example, will just look at this and say, oh, that's fairly straightforward, basic stuff, and it is, but it's about introducing it probably much more into the clinical environment, because I know that organisationally we know how to do this, and we do it, but kind of doctor in training use it as a QI project. As I said, there's interest in general practice. Is it a good way of thinking about assessing risks locally? especially if you're designing, for example, a standing operating procedure, and you need the consideration of risk before you do that, and it's part of that as well. So again, we've got guidance on it. We haven't done much about it. It was adopted in Scotland when general practices remobilised during COVID. So practice managers, etc., were using it to do these type of dynamic risk assessments for, again, fun enough, infection control reasons. Any comments or questions at all on that? Of course, I've messed up my time, so I'm just trying to get through this as quickly as possible. Karen.
Yeah, I'm interested in why you're calling it a dynamic risk assessment. So this, I think it's a helpful tool, but to me, the term dynamic risk assessment usually means that something you're having to do on the job at the time, you know, so you're just about to operate on this patient and you're doing a dynamic risk assessment in your head to think, right, what do I need to consider here? Do you know, that kind of thing, rather than something that's kind of planned and documented. So I'm just wondering about the word dynamic. Is it just because it's clear? Is that what you're thinking? It's simple to use? It's
simple to use. It's a continuous process, and that is the name of the tool as such. So it's reasonably well established in that respect. So it's slightly different in that way. We can explain with a wee bit more guidance to why the dynamic element of it, Karen, because that's a good point to raise. I'd never really thought about it before. That is as I say, that's the name of the method as such. Thanks for that. Karen, you might as well stay on, because we were going to do some group work on the safety culture cards, but we don't have time because of my inability to manage this over 2 hours. So we'll just have an open discussion of it. Now, folks, safety culture discussion cards that MESA produced, we adapted them from the air traffic control world for generic use across all health and care teams. We did this about probably 7 or 8 years ago. They are hands down the most successful thing I've ever been involved in. You know, they're used in undergraduate, postgraduate level. They're used in the service, and they're used internationally. We get lots of positive feedback around them. We're adapting them currently to using the clinical training environments just now in NHS as well. The reason I'm picking on Karen is because Karen's Health Board, under Karen's leadership, took the cards and did an absolutely outstanding evaluation for us, which resulted in 3 or 4 YouTube videos getting produced, which we're going to put up on our site as soon as possible. Karen, do you mind speaking to your experience of using the cards in behalf of the teams that did?
Yeah, thanks. So we were trying to get the cards embedded in lots of different layers of the organisation. So we encourage staff kind of very locally to use them, like at the end of local ward meetings or stuff like that. We encouraged that it doesn't need to be the leader of the of whoever's meeting that day that picks the card. So you've got this selection of cards that cover a variety of topics like leadership, communication, resources, etc. So they pick a card. Each card's got about 3 questions on it. And then as a wee group, they discuss what they thought about that, and if there's any actions that, you know, they could take forward in relation to that. So it does 2 things. It starts people talking about stuff that they don't usually talk about, and it also makes them have a bit of ownership to think, what could we do about that? Is there something that we could do about that locally? But we didn't just use it at the ward level, we used it in committee structures throughout the organisation. So I actually took them to the corporate management team, which met weekly. And once a month I would take a safety culture card. And so this kind of high management level, including the chief exec, at that meeting would then discuss whatever I chose the subject was going to be on the safety culture card, and they would come up with actions about maybe our communication on that could be better, or maybe we need to do a bit more deeper dive into this or whatever. So it's an opportunity to have a conversation about safety related issues that might not just naturally come up. So it gives you either a bit of assurance reassurance that actually we are doing well with this one and things are working well, or it gives you the opportunity to pick up something that might change. We also did another couple of things in the wards. We quickly realised that all the staff couldn't get to that meeting on a regular basis because of capacity issues. So we created a poster that allowed, it's a laminated thing that allows you to write in what the questions are for that particular time, and then there's little clouds like thinking bubbles that people can say what they thought about them, so that we could gather in that information locally to decide if there's something different needs to be done about it. And we also had another poster that said, you said, we did. So what was the problem, you said, and what we did about it, so that people could see that something has been changed as a result of them raising the issue at the safety culture card meeting. The thing that's not worked well is we built a system on Langquip to try and record when the meetings were happening, and that's the bit that's not working. So anecdotally, loads of people are telling me they're using the cards and they really enjoy using them, but it's very difficult for me to prove that because they're not taking that other step to record it on the system of which card they've used, etc. But we're continually pushing it out, and I'm continually getting asked for more cards, to the point that I've just made them all up onto PowerPoints so that they don't actually need the physical cards, that they've got a set of PowerPoints for each of the subjects, and they can just scroll through and get the one that they're going to be using that day. Sorry, that was a whistle-stop tour of that.
No, it was fantastic, Karen, because I didn't know the half of that either. And I'm glad you've got a solution about using the cards, because you were going to bankrupt Ness with the amount of cards we were giving you. Yeah, so very quickly, can we get using the tech? Can we get a show of hands for those who were already aware of these cards? You don't mind? So if you were aware, so Angela, 1. So 5 folks, 6. Okay, so they're not as popular as I thought then. But now you've been introduced to them. It's, you know, we can introduce them again, you know, as part of a teaching session, as part of this teaching pack. How they're used, we never mentioned that. The facilitator's notes are actually integrated within the pack, so the different ways they can be used are hugely flexible. So you can be used in a 5-minute, 10-minute brief or debrief. You could do a whole day's workshop, which we're going to do, probably a half-day workshop. We're going to introduce, you go away with a set of the pack of cards, but introduce the concept, the theory of safety culture, and how you can practically do something around exploring the prevailing culture within teams or departments and so on. So that's something that's coming down the road, but again, it could be part of this teaching pack with some facilitator notes. So thanks for that. So I'm going to just bring it to an end in a few minutes, but before that, very briefly speak to a few other tools, which would be in the teaching pack, and again, which we would have facilitated notes for. Now, this is a piece of work in development about, can we take human factors principles or concepts, so the ideas of, for example, number 5 there, work is done and work is imagined, having to be explored, okay, before you start an improvement project. So how can we link up the two worlds of human factors and QI? So what we're bringing to the party here is a set of principles that could potentially be integrated in improvement activity. You know, that point we made at the beginning about the twin aims of human factors is to jointly optimise well-being and performance. I'm not sure that's, certainly my experience, that's not an approach QI takes. It tends to focus on a singular outcome. In that sense, it doesn't necessarily put people or the users of the system at the centre of the process. It tends to, and again, this is general, it tends to focus on the care processes and trying to make them more reliable as such. So these are areas that we're exploring just now about how we can have greater synergy between human factors and quality improvement. So just to raise awareness of this. Now, this is an area, and again, Karen and others on the call are heavily involved in this. So we're undergoing a kind of revamp, if you like, of how we do safety learning reviews. Ness is in the process with Suzanne, who's on the call, of developing both an improvised curriculum around that and also something much more substantial in order to provide accredited training in leading and undertaking safety learning reviews, and hopefully certification as well as part of that. But integral to all of it is this whole idea of systems thinking, the systems thinking mindset. And then Helen Ross mentioned this at the beginning about how do you translate some of these concepts into the real world. And this is an attempt to do that by, getting safety reviewers much more familiar with systems thinking principles and concepts. So if you take these 12 concepts together or principles together, they form a kind of a philosophy or a mindset that we would love to inject into the minds of people who are leading reviewers, because hopefully they'll lead to much more meaningful, effective reviews, and also are kinder on the workforce in this respect as well. So I won't say too much about it. We've done a lot of work in this. Again, it's been done jointly with NHS England and the Healthcare Services and Safety Services Investigation Branch down south, but it is NEST led, and we are beginning to drip it into some of the patient safety learning work that we're involved in, our care safety learning work. Finally, this has been around since the beginning of COVID. Human-centred design principles for what we call work procedures. It's just a generic term for policies, standard operating procedures, protocols, checklists, care bundles, anything like that. I think there's definitely a learning need in the service. That there's, if you look at safety incidents, around 60% of them, the work procedure was cited as a significant contributory factor in that incident. But what we don't know is that there's a science that underpins how you design a work procedure, how you implement it, and how you sustain it. Okay, and this is an attempt to provide some guidance on that. And I know from a clinical perspective that no folks are trained in this. There's an assumption made that when you go into practice, that you can design and develop and implement some type of work procedure. And often, and you all have experience of it, there's huge variation in their quality and if they're used or not, or even where you can find them. So again, I think we've identified a significant learning need here. One of my ambitions is to get this into clinical training in some way, even at undergraduate level. And I know that Helen Vosper is certainly doing that in Aberdeen. So I'll just very quickly talk about, you've been introduced to very rapidly, I get that, to a lot of concepts, a lot of tools here, which would form this brilliant basics teaching pack. There are some of the potential learner groups that we've identified that could be targeted in that sense. I think I said at the outset, the idea would be that once we agree on it and we'll co-design it with yourselves, whoever's interested in helping here, we'll place it on the TURAS learning platform as well. So before I hand back to David, any final points, questions, queries, clarifications around probably the teaching pack as such? I'm working on the assumption it's a step in the right direction. Okay, you just want it out there quickly, right? So Suzanne's working on a draft, which once we get it developed, hopefully in the next month or so, we'll put it out for feedback. Okay, just to get initial thoughts on it before we do something a bit more formal with it. It's our attempt, and it's a small attempt, to try and counter those myths and misunderstandings and fallacies that are ongoing, and try and get a consistent approach in Scotland to how we understand human factors and how it's integrated within health and care, education, risk and safety and improvement, and so on. So on that note, I will thank you very much indeed for staying the course, and I'll hand back to David. Thank you.
Thank you very much, Paul. I'm not going to keep us too much longer. Sarah, did you just want to pop in quickly before we wrap up? Paul, loads of rounds of applause going along there. That's been a really different 2 hours in the middle of my Friday this week, but really fascinating. I've learned a ton of stuff there, and you've really made me rethink a lot of what I make assumptions on, like I said in the chat way at the beginning. So thank you so much, and to Helen in her absence, and to Sue as well, who's still on with us, for taking the time to provide this opportunity.